My name is John Mazzio. I'm the director of the Master of Public Health program here at DePaul University, and I'm happy to present our next breakout session, entitled Empowering Students in the Face of a Pandemic, Organizing a Response to Support the Homeless Community During COVID-19. The session is going to run from now until 12:20 p.m. And as a moderator, I'm here to support in whatever capacity you need as presenter. So please let me know if there's anything you need. I'll be on. And if questions do come up and you may not see the chat, I can point that out for you. And I'll also let you know 5 minutes before the session's over that we're coming close to the end of time. So I will turn it over to your group.
Great, thank you, Dr. Mazzio. I'm just going to share my screen. Okay, can you see my screen okay?
Yes.
Yes, great, all right. Just to start off, hi, my name is Cary, Kane. I'm one of the students presenting today. We're here to chat about a student response to the COVID pandemic, specifically supporting the homeless community in Chicago. Oops, sorry, I don't know how to advance. We have no conflicts of interest to report. We have 3 learning objectives today. First, we hope that participants leave able to detail the unique challenges faced by individuals experiencing homelessness in Chicago, specifically during the COVID-19 pandemic. Second, we hope that participants are able to understand the strategies that a group of students used to support this community during the pandemic. And 3, we hope that participants feel empowered to creatively address health inequities among vulnerable populations in their communities. One quick disclaimer is that we are using slides today, and there are going to be certain activities where we're encouraging folks to write into us. So if you have any accessibility needs, particularly visual, and so you'd like some support with that, please send a private message in the chat to Zoie Sheets, one of our presenters, and we'll do our best to accommodate. These are our presenters for the day. We're 7 students. We're from University of Illinois, Chicago and Rush Medical Center, and we're M1s and M2s. And with that, we'll begin.
I think we can go to that. Awesome. So just to get started, I want to address some frequently asked questions that were asked about the pandemic. Most of this information is probably common knowledge to folks in this breakup by now. But at this point in March and April, when a lot of the screenings that we were doing were occurring, it certainly wasn't common knowledge to most of our volunteers and shelter guests that we were working with. So it's important that we clarified and explained the challenges we were facing and why we were doing this for public health. And a lot of that centered around ensuring folks understood that COVID-19 was transmitted person to person, that there were many different symptoms, but most commonly it was fever, cough, shortness of breath, chills, and muscle pain. Now we also know there's a few other ones associated. And then we also needed to communicate and ensure reliable public health strategies like mask wearing and social distancing were understood, and that there wasn't any reliable treatment, so that prevention was key to making sure spread of the infection was prevented. Finally, we needed to communicate who was at risk and why. So we know that while older people with certain health conditions and immunosuppressed people are not the only ones who can get serious complications from COVID-19, they're the populations that are most at risk. And that's where we wanted to focus a lot of our efforts. An important thing to point out also is the fact that people over the age of 50 make up nearly a quarter of the homeless population, and that percentage is only likely to grow. So it is a really at-risk subset of the population. So I wanted to include this slide in here just because this is the rate of COVID-19 infections in Illinois per 100,000 residents as of a couple of weeks ago. And as we might have been hearing on the news, we've been hitting daily national case records, over 100,000 a day. And that also holds true in Illinois. And that sets up what's going to likely be a long winter. And this work is more than likely going to continue in through the next few months. And then if you look at the top right corner of the map, you see in dark purple is Cook County, where a lot of this work happened. It's one of the hardest hit counties in the entire state, which is where Chicago is. So this is another chart kind of reiterating the last point. Around March through May of this year, we saw the positivity rate spike. A large part of that is possibly due to the fact there was really limited access to testing. So the folks who were able to get testing likely had COVID-19. And we've seen that level off over the course of the summer, in part because of the fact that nationally we've been able to get, and throughout the state, we've been able to get the pandemic a little bit more under control, as well as a greater access to testing. But if you look at the end of the chart, we're starting to see it creep up a little bit. And this pandemic is really going to come back in full wave again. And a lot of the skills that we've developed throughout this time are really going to be important again. So some populations are definitely disproportionately impacted by COVID-19. There's a lot of rhetoric out there that that the virus doesn't see race or doesn't see any sort of demographic factor, and that's not necessarily true. So I couldn't find any information directly about Illinois, but in New York City, mortality rates due to COVID-19 was 117,000 people, or 117 deaths per 100,000 people throughout the city. But for homeless shelters or homeless New Yorkers specifically, it was 184 deaths per 100,000 people. That's an increase of 57% higher than the average New York City rate. So we see that there's a big difference in who is vulnerable to the virus. And finally, hitting home that last point about disproportionately impacted populations, a study from Vox throughout the nation found that Black Americans, as well as Latinx, Pacific Islander, and Indigenous Americans were far more likely to die from COVID-19 than white Americans. Also, a disproportionate number of homeless individuals in Illinois and in Chicago are Black. So that's just another thing to keep in mind. The last slide for me for the moment is between March 1st and May 1st, when a lot of our screenings were occurring. We found that there was a 27% COVID tested positivity rate in homeless shelters across the city of Chicago. And statewide, at the same time, the positivity rate ranged anywhere from 12% to 24%. So we see the positivity rate is significantly higher for people who are experiencing homelessness.
Thanks, Paul, for that background with COVID. So I want to talk a little bit about Chicago's homeless population. It's important to get background information before we can continue going further. And one thing to note is that when we're talking about these things as a whole and communities, disadvantaged communities being disproportionately impacted, it's important to realize that there's long-term structural issues and systemic issues that are leading to this. So first, to talk about some statistics, Chicago runs what's called a point-in-time report, and they did one in 2019. The limitation of a point-in-time report is that it's literally that. You're looking at one specific point in time. So it's where volunteers go out on one day and get an estimate of how many people are in shelters and how many people were unsheltered. And you can see that breakdown over here. Some important things that they look at is homelessness for the first time, which you can see is about 40%, both with unsheltered and sheltered individuals. And then one thing that we want to do is kind of dismantle this stereotype view of homelessness, and that families can be homeless too. And when we talk a little bit about factors leading to homelessness, it's not going to just be single individuals. There could be families living together in shelters due to unfortunate circumstances. And then another thing is chronic homelessness. And when we talk about chronic homelessness, we're talking about individuals who are either have been homeless multiple times for a prolonged duration, or people who were homeless the entire time for a prolonged duration. Now, another way to look at the statistics is to actually look throughout an entire year and see how many people have experienced homelessness in Chicago. And the Chicago Coalition for the Homeless ran this estimate in 2018, where they found 76,998 people in Chicago had experienced homelessness. And another thing that we want to talk about is homelessness also includes the idea of couch surfing or doubling up, and this is going to have implications for our youth. communities that are experiencing homelessness. And an unfortunate thing about this is sometimes this definition is not recognized as part of being homeless. And so that might change the way we look at eligibility criteria. And again, this is from the Chicago Coalition for the Homeless, and that you might end up excluding people from essential programs that could be helping them if you don't consider these types of definitions. Now, another thing, and going back to this idea of we have structural racism and systemic issues, homelessness disproportionately impacts Black and African-American Chicagoans, and this is here in our city. Despite only 1/3 of the population being Black, around 70% of the homeless population is Black or African-American. So what are some factors that drive homelessness? So I want to, before talking in a further note, that many of us here today might have lived experiences where we identified as homeless at one point, and this can happen to anyone. And some of the reasons, and this is not an extensive list, that this happens is loss of job, history of foster care, history of incarceration, substance use disorder, disability, mental health, domestic violence, or identity-specific violence. And to kind of just give you a further idea of that, sometimes there are catalysts that can't be controlled that propagate homelessness. And unfortunately, there's not, like we talked about, a lot of assistance or ways to get back up, is that some things to keep in mind is 1/4 of the sheltered population reported being employed. That again is a stereotype, and that homeless individuals can be employed, and a lot of them do have education goals or are seeking an education. A lot of them do have jobs that they're trying to maintain while maintaining a living situation. And for when we talk about youth, unaccompanied youth who are homeless seldom stay on the street or in a shelter. So this goes back to what we were talking about with couch surfing or doubling up. And then the last thing to keep in mind is that about 30% of both populations being sheltered or unsheltered, and owned or leased a place before becoming homeless. So these are people who were living their normal lives, and then unfortunate factors driving homelessness push them to no longer have a steady place to go. So thinking about those factors, I'm going to toss it to Zoie to talk about some unique challenges in the homeless community.
Thanks, Amel. So now that Amel has talked about some of the things that may lead to someone becoming homeless, I want to flip that a little bit and talk about the ways that these experiences can also impact one's experience while being homeless. So as a whole, the homeless community faces a really vast amount of stigma, and I'm going to delve a little bit deeper into that in my next 2 slides. So I'm going to kind of save that one for now. Another issue that they often face is being stripped of their autonomy. Something that we witnessed in the work we were doing was the way that sometimes shelters, just because they have so many people who need so many different things living under their roof, is that we kind of get this vibe almost as if we're like herding cattle. That's a phrase that I heard someone use, one of the shelter residents use. And while I don't think that's ever the intention, that form of having your autonomy stripped can really impact your well-being. Another thing is othering. I'm sure that folks have kind of witnessed the way that as people walk down the street and see someone experiencing homelessness, they may just ignore them, not smile at them or make eye contact. That's just one example of the ways that people experiencing homelessness are often othered and kind of have their humanity diminished once they may be on the streets or living within a shelter. In the box on the right, you see some of the things that some of the identities or unique experiences that people experiencing homelessness might face as well. The first one being employment or education. So not only is employment or education that can be a challenge for a lot of people to access, right? But specifically people experiencing homelessness, with the stigma that they're facing, combined with the fact that they don't always have access to having a state ID or having internet access, they may struggle to find job applications to continuing their education, etc. Amel touched on the fact that families can be homeless, and I want to add to that by saying families also experience really unique challenges when they're experiencing homelessness. Not every shelter allows a family to come in the door, and many of the services that are geared towards the homeless community are adult specific. It's rare to find programming specifically for kids experiencing homelessness. Transgender and non-binary communities, as well as other members of the LGBTQ community, may struggle to find shelter spaces that accept them. They may either be outright denied access to a shelter or forced to hide their identity while they're living in a shelter. This is particularly true for shelters that have kind of a staunch religious perspective. And within Chicago, those shelters are pretty frequent, unfortunately. People with disabilities and shelter accessibility, there's actually a really extensive research study being done right now by Access Living that's looking at the ways that shelters are often inaccessible for people with disabilities. And I want to be clear that when we say shelter accessibility, we don't just mean like they have ramps and they have beds that people can transfer to out of their wheelchair. We also mean folks who might be autistic or neurodivergent, needing spaces that are welcoming to the way that their minds and bodies work as well. This is true for all people with all types of disabilities. Mental illness, including substance use disorder and shelter access. If you need regular access to a substance to prevent yourself from going into withdrawal, you may not have that while you're at a shelter. And then former veterans are not only at higher risk of becoming homeless, but many former veterans have post-traumatic stress disorder, mental health conditions, or disabilities that make all of the things I just talked about also relevant for them specifically. Going into the stigma, there are a lot of myths out there about people experiencing homelessness. And so I'm going to touch on just 4 of the most prevalent ones. These myths and the truths accompanying them were compiled after I spoke to about 100 folks experiencing homelessness who are a part of the South Loop community table dinner party that happens in the South Loop every Sunday night. And so while I am the one who typed them onto the slides, I want to be really clear that these ideas are from the community and not from me. The first myth is that homeless people don't have jobs. The truth is that homelessness is complex. Having a job doesn't automatically mean that you are able to find stable, affordable, accessible housing. Many people experiencing homelessness do actually have jobs, but even those who don't are still human beings who deserve respect and full support. Homeless people are all addicts. We have an asterisk there because we want to be clear that we're typing the word addicts and addiction because that is the word that these folks felt they were labeled by. We recognize that in order to combat stigma, it's more appropriate to use words like substance use disorder, but we wanted to reflect the label that these folks feel like is being put on them. So myth, homeless people are all addicts. Truth, addiction actually is prevalent in the homeless community. That's true. While certainly not everyone experiencing homelessness also experiences substance use disorder, those who do often have a background of trauma and haven't had access to effective, safe mental and physical health care to cope with this trauma. And so we think it's really important to remember that substance use disorder is not a moral failing, and these people still deserve respect and support. The third myth is that people experiencing homelessness are less intelligent or talented than housed folks. Most folks, if you ask them, wouldn't readily admit that they think people experiencing homelessness are less intelligent or talented, and they may not actually believe that either. Where this comes from is really the way we interact with people experiencing homelessness. The tone of voice and the body language we have can be condescending and can communicate that we think they are less than. So remember, homelessness does not reflect IQ, talent, or success. It reflects systemic injustice. And finally, homeless folks are lazy. The truth is that surviving while homelessness takes a lot of resilience, wit, and hard work. Again, homelessness is not a reflection of individual characteristics, but instead it's a reflection of systemic injustice and disinvestment. So we've talked a little bit about, I almost forgot this slide. Shelters with student support. We wanted to make sure as we transition to talking really specifically about the COVID-19 pandemic, you knew the shelters that we were present in while we were doing this work, the shelters that we have experience with. So all of the shelters on this slide had someone present doing this work within it. I specifically was at Pacific Garden Mission alongside Amel and Paul. Okay, so now that we've had a chance to kind of talk about homelessness in general, who may be impacted by homelessness, what they may face once they become homeless, we want to really fit all of that within the pandemic now. So all of that was broad, all the time information. What about during the COVID-19 pandemic specifically? What challenges were faced by this population? And so we want to give you a chance to kind of reflect on that before we delve into the things that we witnessed and heard from the members of the community. So on the next slide, you're going to see just a blank sheet. And so what we're going to ask is that we have folks actively participate in reflecting on that question using the annotation feature. So on this slide, tell us, what do you think are some of the challenges that people experiencing homelessness face during COVID-19? To participate, what you can do is go to the top where it says you are viewing Cary Ann's screen, click view options, annotate, and then text. So that's view options, annotate, text. And then you'll be able to type, you may be able to see that I typed the word hello onto the slide so that we have a mix of everyone's thoughts all in one slide. We'll give you a couple minutes to do that and let us know if you have questions.
Can you also repeat the prompt just in case some people are?
Sure. It's now at the top left of this blank slide. We're talking about challenges faced by the homeless community during the pandemic.
Also, if folks are more comfortable not or like can't figure out how to use the annotation feature, you can also type it into the chat and we can talk like verbally say it aloud as well.
So as we let folks keep annotating, I'm just going to read aloud the ones we have. Some of the challenges that folks think were faced by the homeless community during the pandemic are food insecurity, depression and isolation, clothing, access to healthcare, not having a computer, further isolation, medication, and seeing friends. We'll give you about 30 more seconds to kind of, someone added in the chat, isolation and fear. I'm really seeing the theme of isolation. I think that's definitely true. That's something Amel's going to speak to in just a moment. Take just a couple more seconds to add your thoughts, and then we'll delve into some of the things that the community expressed to us were the challenges that they were facing. I saw no PPE be added in the chat. Okay, so as Amel kind of takes us through these, just keep all of this in mind. I would say that all of this is true. All of these are challenges that we're being faced. So really hold these in your mind as we continue this conversation.
All right. Well, thank you guys for participating in that part. And I think a lot of you were nailing it pretty much right where it is. And a lot of that is true. And a broad perspective, what we're going to talk about is first thing first, a lot of people always mention when you think of a pandemic in the fact that we needed to have isolation and social distancing, isolation being, keeping away from others and quarantining, things like that. Those are definitely really difficult when you're sharing a living space and you might be in a facility that doesn't have the extra space to do that. Another thing to think about when we're looking at communal living spaces as a whole, and somebody mentioned PPE, difficulties meeting infection control sanitation needs. You have a little bit of a different population where you might not have the resources you need to be a little bit more stringent when it comes to hand sanitizing or the way bathrooms and other facilities are used. I saw somebody put in their clothing. Laundry is really important, especially when we have cloth masks to talk about. And we're going to get into some of that a little bit later too. I saw people saying fear and isolation, and I think those are really real things, which ties down kind of to these last three when we talk about communal living spaces is boredom, lack of worthwhile activity. A lot of the shelters that we were at had lockdowns, meaning that you could not leave the facility, and if you did, there wasn't really an option for you to return because it was part of infection control efforts. And then autonomy, a sense of having control of your life when you're in a pandemic, even in general, I know for myself, I felt at one point in time very frustrated, and I can only imagine the sense of autonomy is a really important thing that was a little bit threatened by the pandemic. I saw someone mention healthcare. That is huge. We have 30 million people right now who are uninsured in America, but the homeless population definitely is disproportionately impacted by access to healthcare. When we talk about providers, not a lot of places have primary care in the first place, and we'll get into that a little bit later about why that's really important. PPE was mentioned, medications was mentioned, medications from both prescriptions, over the counters, or even substance use. And then two really big things to talk about is health literacy and medical mistrust. It's important to recognize that the history of medicine has taken advantage of communities in the past, and that these could be leading to a mistrust against the medical community. So when you come into a space that's not really yours and you're a transient person there, it's important to make sure to respect someone's autonomy, but also know that that mistrust could be there. And health literacy, while not a reflection of intelligence, but rather experience and resources, can also play a role. If somebody doesn't understand the way a virus is being spread, they might not get why they need to wear a mask when they haven't had to in the facility before and things like that. The other thing to talk about is comorbidities. The homeless population has high rates of chronic illness. This could tie back to access to healthcare, among other things. Substance use disorder, mental health, trauma history. And then I want to mention aging. The thing about aging with the homeless population, there's data to show that given a lot of the history of trauma and or difficult circumstances, the homeless population might age differently, especially for those who are experiencing chronic homelessness. And so that's a risk factor for COVID. And that's an important thing to keep in mind when we move forward. So for our initial approach, how did we tackle this? This is going to be pretty broad, but we're talking about global considerations in decision-making. There's two must-haves. First is community-driven decision-making. Like I mentioned earlier, we're students coming into a space that we have to recognize might not be for a long term or a transient effort. And so it's important to respect the culture and community of the shelter that you're entering, especially given that you are someone who's more so like a visitor there. And then the other thing too is prioritizing people-centered decisions, balancing medical need versus patient autonomy and humanity. So for example, if you needed to take someone's temperature, but they didn't want a thermometer in their ear, having that conversation with them and giving them that time to understand why it's important to get that temperature in the first place. So when it comes to working with the community partners, who are we working with? I have shelter residents here in italics because it's important to make sure that you're hearing what is being said by the residents and what their concerns are so that you can communicate it to other things like providers, shelter staff. Students were a huge part of the effort. City of Chicago, advocacy groups, independent community involvement. So that's a thing to keep in mind. When we talk about independent community involvement, that's got to be more like we ran a fundraiser at one point, so the community can be involved. And we have a generation of social media and technology, so it's powerful what you can do. The other thing is we were working in closed shelters. So the consequences to that, and some of that was mentioned during our whiteboard activity, is access to prescriptions, employment. So a lot of people had voiced that they were concerned about their job. And I saw on the screen that somebody had mentioned computer and internet use. That's really important. Scheduled programming. Shelters like PGM had programming that was already taking place. So it's important to keep that in mind when you're trying to bring in a different effort. History of trauma, leaving against medical advice. That's what leaving AMA is. Visiting families. People who are living in shelters or who are unsheltered do have families, and so they might be concerned about the well-being of their families or wanting to travel to meet them. So those are some things about working with community partners. Real quick, because we are students, it's important to note that we had to work with academic institutions. And if you're a student, this is something you may have to face as well. So there are 3 challenges, but there are solutions to these challenges. Liability. So a lot of times institutions do not want to be liable, especially during a pandemic. This is something unforeseen and we have not had in our time. So what we did is we just noted that we had been independently volunteering. This was a choice that we made. And to have discussions with your institution, you might find that they're willing to help you, kind of like how Rush ended up having a collaboration with their leadership, and they even were able to get supplies, PPE, and funds through Rush. Safety concerns, what we did is we had standardization in a training document. So basically this helped to address whatever safety concerns there were, how to don and doff PPE, and how to make sure flow is organized so that everything is as safe as possible. The last thing is that sometimes when you're, especially if we're a medical student and you're working with a provider on the field, you might be navigating student-teacher relationships in a realm that's not the institution itself. And so sometimes that can be challenging. But that's just something to keep in mind. Navigating it is going to be about frank, open-ended discussions with your faculty. And then just like how we did for liability concerns.
Yes, so one of the biggest things that we did is just like we mentioned at the very beginning, the people didn't know what to do. And so to protect our safety, a lot of the institutions actually closed down and prevented a lot of its students from volunteering because we didn't know a lot about COVID. We didn't know if it could be infectious, how deadly it is. There were so many questions up in the air back in March of 2019 or 2020. Yes, 2020. Already confused of the year. So what we ended up doing is we started in more of a virtual way. We started to see, okay, well, we wanted to help. There has to be other students that also want to do something instead of just sitting around all the time. So that's where we use social media. We use social media to spread the word and be like, hey, we want to do something. These homeless individuals who are now in these shelters, they have so many needs. Who else is willing to help? And we were so impressed with the response. We got individuals from across even the country that were willing to support us virtually, and also the people who were local were able to volunteer in person. So that was our first step, is really spread the word and develop kind of a task force. And then as different shelters or community partners would tell us their need, we would then spread the word to our new task force to let them know, hey, this new volunteer opportunity came in, who can go do it? And we would send them off. So that's kind of one of the big things that we actually continue to do to this very day. We send out emails to our long list of volunteers, and as needs come up, we send them out. And especially as November, December come around, everyone knows we're already in our second wave of COVID. We're even more actively getting out there and getting our volunteers.
So we're now transitioning to a little bit more of our on the ground work, specifically the screenings that we conducted in the shelters. So once we had recruited those volunteers, it was really important for us to ensure that everyone knew how to conduct a training and had the skills to do so, because we wanted to make sure everyone felt safe and supported for the entirety of the work. So things that we recognized pretty early we needed to train our volunteers to be able to do was setting up and conducting a screening safely donning and doffing PPE, cleaning the PPE and their personal items like keys or phone that they had with them afterwards, and communicating with the residents of the shelters about what was going on with COVID and why the screenings were happening and things like that. This is particularly important because many of our on-the-ground volunteers were health field students that hadn't maybe completed all of their training yet. So for example, I had not previously learned how to don and doff PPE. And so it was really important to ensuring the safety of everyone that we develop some sort of training plan. One thing that we did to ensure that our volunteers understood what was going on when they showed up for a screen was create a training manual for people to review at home. we tried to cover everything in that training manual that we could think volunteers might need to know. So that included general safety, the roles of every team member, what PPE we used and how to use it appropriately, including a video you can see a screen shot of. We included screening instructions and diagrams detailing the different layouts of different shelter spaces, because every shelter was slightly different. And we also included cleanup information and mental health resources, because it was really important to us that these were mostly students, but community members who were dedicating more time in an already stressful time, and we wanted to make sure everyone felt supported and safe. And so that was sort of the at-home part of the screening. The in-person part were the site coordinators. So every day when we had a screening at a shelter, we had at least one site coordinator on hand. And these were pre-trained volunteers who had been here before and had, knew how to run a screening at the shelter. And they sort of ran the show for the day. They ensured that everything was set up and that the screening was conducted safely. They taught new volunteers, like they oversaw like the donning and doffing of PPE and the proper cleaning of face shields and personal items afterwards. And they also conducted any necessary follow-up needs after the screening. So that would be like recording the number of guests that we screened that day, following up with a physician about any positives that we found, and documenting any equipment needs so that we'd be prepared for the next day as well.
Okay, and I'll talk a little bit about the actual screening protocol itself. So on the right, you can see an example of the setup we had at the YMCA. So guests would approach the screeners and answer screening questions. After completing said questions, guests then receive a temperature check, either oral or forehead. And then if guests have passed questions and their temperature checked, they're clear to go back to their respective common areas. If a positive result is received either on the questions or with the temperature check, that'd be over 100. They would be redirected to the physicians who would further evaluate them for possible isolation. And this is just a quick look at the questions and the temperature check. So, cough, shortness of breath, body aches, fatigue, and so on. So like I said, like was mentioned, I think we were at 5 or 6 different sites. So each different site had different space limitations that each developed their own variations of the screening protocol. What we did make sure to remain consistent was obviously temperature and screening questions, and that physicians always had a designated space to evaluate those potential positive cases.
So we're going to do kind of the same thing as we did before. We're going to have a question, and then we're going to have a whiteboard. And if you guys could all, or you all could all type up your answers. The question is, beyond direct illness, how could COVID-19 impact the lives of those experiencing homelessness? We kind of talked about it before. We'll give it like a minute on the next slide. And we'll also put it in the chat. So just a reminder, go up to the top, you click View Options, and then click Annotate. And you're welcome to put in the chat if you can't figure out the annotate. Give about 15 more seconds. So I see a lot of great ones. Chronic mental illness is definitely a huge issue, not just in the homeless population, but throughout the entire world right now. People are changing up their schedules, being locked inside. There's a lot of mental illness going around, social isolation. So we're gonna go, oh, thank you, access to substances and medications. That was a huge challenge too. If the individuals had to be stuck in the shelter, they weren't allowed to leave, that means they couldn't get their substances. And substance abuse is a mental disorder, and they can go into cravings, that they can they might need to even go to the hospital if they're having severe withdrawals. Loss of friends, yes, death. Fortunately, there's a lot of death going around, especially in these high-risk medical, where there's a lot of medical conditions. Food, yes, definitely. There's not all shelters have the money to provide the best food, or even the food that they maybe want. So great, we're gonna go. Thank you everyone for participating. There have been really good ones. We're gonna clear the screen and keep going. So a lot of you all mentioned similar things. So we also wanted to add lack of physical activity, sitting around versus maybe usually they're walking long distances to walking to their shelter, walking to their job. Like instead of when they're at the shelters, they're just sitting there. Hygiene products was also a big one. A lot of them, not all shelters had showers, and so, or had soaps that they could use. Someone mentioned before laundry. That's a big one, especially being in the same clothes day in, day out. That is not fun at all. So definitely there's a lot of different challenges that just exacerbated during COVID-19. Perfect. So this is where, in addition to the vital projects of screening the residents, we also have a lot of other projects, and a lot of these projects we've continued, and we expect to continue into the next year. Some of the things that we did initially is providing a lot of educational materials. So we collaborated with Cook County Hospital. They created this, on the right, there is a guide to COVID-19. They did it in both English and Spanish, and tried to make sure, and I believe in Polish, because we have a huge Polish population, and a couple other languages they were trying to do. And we had student volunteers pass them out through all 77 shelters. That was a big thing. There have also been other educational sessions. For example, Narcan sessions are currently going on, and that, for those who don't know what Narcan is, if individuals overdose on an opioid, if you have Narcan available, you press into the nose and it allows them to wake back up until they're able to get to the hospital. And since opioid use is common, unfortunately, a lot of the individuals in the shelters and the staff members really appreciate learning about this Narcan. So that is something that they're continuing to do. PPE distributions. If anyone remembers, there was a huge month or two that there was no PPE everywhere. And thankfully, since our team works so close to the city of Chicago and the health department, we were able to get multiple hundreds of thousands of PPE and do a systematic distribution, making sure all the shelters received the PPE. Medications, we were able to deliver medications to the shelters since they were not able to leave. And then on the next slide, we'll talk about the care packages. So the care packages were great because this is where we really got the community involved. A lot of the individuals in the community were like, hey, we want to help too. And so we had the community donate extra supplies. You see toilet paper, you remember all the toilet paper that we needed a lot. So yeah, and then we had student volunteers go in and make care packages. And these are so important because they provided something positive to help the mental. It's so important in the homeless community to have something physical. And so when they received this care packages, care package, they felt like they were welcomed, like they were accepted. And so these were so important in so many realms, and we're continuing to do those, and also into the next wave. And then the next slide, I'll very quickly touch on the isolation center. So this is the one and only isolation center for COVID positive individuals throughout Chicago. And so we are currently spreading the word of this isolation center, which is free through student volunteers. So we just earlier this week, we got 100,000 flyers, and we're distributing them to all the COVID-19 sites and health centers. So if you are interested, we'll talk at the end of how you can get more involved.
Great. So now that we've had a chance to do a little bit of reflection and to learn some of the things that we were facing as we worked in the shelters, we want to give a chance to apply those things. So we did a few whiteboard activities, but this is going to be a little bit more involved. As we were working in the shelters, we had several things come up. I would say several things a day come up where we were kind of like, okay, how are we going to address this? How are we going to remember the things that are important to us, which is respecting people's autonomy and making sure that we're continually building trust and logistically navigate this barrier that's coming up. And so on the next slide, we have a few options of things that you can talk about, or not options, 2 questions about an issue. That is something we actually faced regularly within the shelters. And so we're going to split into breakout groups, and it's going to be 2 breakout groups for 10 minutes. And we're going to talk about this prompt. A shelter resident approaches you and says they're considering leaving the shelter because they don't have their insulin anymore. The shelter is currently on lockdown, and if they leave, they're not going to be able to come back into the shelter. How would you address this concern today for this patient who's right in front of you? And how would you address this concern systemically for future patients? Inevitably, there will be more patients who also need access to their medication. So I'm going to have, perfect, there we go. So go ahead and join a breakout group and take about 10 minutes to brainstorm how you would address this.
Can everyone see my screen again? Okay.
Yes.
All right, shall we move on to the discussion part?
So I'd love to hear some of the ideas that came up in the breakout rooms. What are some things that we can do to make sure that folks have access to what they need? Feel free to put it in the chat if unmuting on Zoom is not your thing. Taylor, can I invite you to share what was talked about in our breakout room?
Yes, I would love to. So we had someone mention something that was really important whenever we're trying to think about developing a system to address a need like this, making sure that we're getting feedback from the folks that we're developing the system for, to make sure that we're always doing more good than harm, because we might think it's a good idea, but if it actually places more burden on the people we're trying to help, that's not an effective solution. Some of the things that we offered and some of the things that were actually done was some folks did just go pick up the prescription for that person. Not the most effective, use of time in terms of like finding a systemic solution, but for that patient in front of you, sometimes like going to that next step and to that next level and getting them what they need in that moment is just really important. And really, I think also in this context, it was it's a way to demonstrate that you do really care and are listening to the needs that they're telling you directly. And that's important for forming those relationships of trust. And then on a more systemic level, one of our participants mentioned that they would hope that, shelters would have relationships with a pharmacy so that there could be like some type of development of a delivery system, from pharmacies to shelters, or some type of, kind of a reciprocal relationship. And unfortunately that doesn't exist, but that's, that's something that was kind of attempted in terms of like doing, batch pickups for medicine from certain pharmacies that were closest to the shelters. But I think the responsibility really came down on the volunteers that were in the shelters to do that type of service. So that's what we talked about in Shah.
Thanks, Taylor. Does someone from the other breakout room want to share?
I can share a little bit.
Perfect.
We had a very similar discussion, focusing on like mail-in orders and being able to connect the dot between the shelter and the pharmacy. And actually for at least one of our shelters, we were able to establish a relationship where shelters or the pharmacy was able to occasionally deliver medication, which was really huge. So I think it just depends on like what the area is and what the pharmacy is, and whether it's like a bigger one or a smaller mom and pop pharmacy. But I think that basically we talked about the same things that you guys did.
Well, I'm really grateful for the folks that engaged in this. I think that being able to brainstorm, and even if one thing has been tried, coming up with things that might be even more effective than the thing that's been done is really key. That level of being willing to be flexible and adapt and try things and admit if they're not working and try something new is really critical when responding to any situation, but particularly a very quickly evolving situation such as the COVID-19 pandemic.
So I think we want to start talking about outcomes and lessons learned now. And I think a lot of the lessons that we've learned are going to very quickly be put into play again. And hopefully we can avoid some of the mistakes that we've made before and react a little bit quicker from these lessons. So the first lesson we learned is that it really does take a lot of people from a lot of different perspectives and different skill sets to effectively make some of this change happen. So we faced issues from myriad fronts, and oftentimes we needed to work together with people from various roles to get things done, whether this was student leaderships, medical providers, shelter staff, administration, various volunteers, etc. it really just takes a collaborative effort. And there is always a space for whatever skill set and whatever contribution you're able to make for it to be helpful. So it's okay to make an effort to reach out to whatever causes that you have access to. And even if you're not sure how to help, put a foot forward and see what you can do. Another important point that was mentioned throughout this entire presentation was to make sure that we're not causing more harm than good. And a pretty important and easy way to do that is to just ask people what they want, what they need, and then listen to them. And be willing to adjust your plans, be willing to adjust what your thoughts and hopes are, and be receptive to what people feel that their needs are and what resources they want. These priorities are fluid and they change, and we need to be willing and able to change with them. And then a final couple of points is effective communication and collaboration. Yes, effectively communicating and collaborating with people that you're supposed to be serving, but also the people in your own team. This really is a team effort, and expectations and goals need to be cleared and agreed upon. But new feedback and new ideas need to be welcomed and really critically evaluated. So the folks that you find yourself working with in these spaces are there for a reason. They might have different backgrounds, like I mentioned before, but they really are bringing new perspectives to solve challenging problems. And attitude in these situations makes a big difference. This is really hard. This is going to be really hard. And it's going to take committed people who believe in what they do, and they believe they can do the right things for the right reasons to get things done for the benefit of others. And finally, flexibility and failure they're part of the process. Sometimes you'll have what sounds like a great idea, what is a great idea, and it just won't pan out. And that's okay. Try it, think about it, and if it doesn't stick, just keep moving. It's all part of the process, and eventually you might get a system that works. And on the other hand, you might have a strategy and system that's worked for a while, and you'll face a challenge that day that completely blows up what you've been doing. And that's okay. You'll have to make adjustments on the fly, and that's something that that we've all had to learn in one way or another.
Okay, so now that we've explored some of the work and thought about, the effects of the work, I want to talk about some short-term and long-term outcomes of our collaborative efforts in the beginning of the COVID-19 pandemic for the homeless community. And the first point I want to make is that our work, especially the screenings, were really an important component of infection control. And so you'll see on the right here, there's a graph. So we'll be using Pacific Guard admission as our example, and I want to bring attention to the highlighted number in red, which is a 45% positivity rate. So when the pandemic first started and testing capacities were really low, the student-run screenings were truly one of the initial methods of infection control. So this week of April 8th, you can see that 45% positivity rate. And the reason that we were able to get the testing team into the shelter is because we initially had extremely high rates of positive screenings at PGM. And so we were actually the ones that were able to mobilize the testing team and help manage and mitigate that initial outbreak at PGM. You can see in subsequent rounds of testing in the further weeks, that positivity rate going down, which to us signifies an effective mitigation of that initial outbreak. And that was really brought about by the initial screenings. One of the other important outcomes that I want to highlight, and probably one of the most important outcomes of the initial response to addressing the COVID-19 vulnerabilities and concerns in the shelters, is that this work actually really shed a light on a persistent lack of reliable healthcare and consistent medical management for folks with high rates of chronic illness in the shelters. And so the Chicago Homelessness and Healthcare Response Group for Equity, otherwise known as CHARGE, is one of the major ways that we have come together to respond to this issue in a longitudinal fashion. So this is a collaborative of healthcare providers, representation from shelters across the city, leaders from nonprofit organizations dedicated to serving the homeless, and city representatives from multiple departments who have taken on the intersection of homelessness and healthcare as their mission. We meet weekly to discuss various initiatives, policies, other programs to help fill and close that gap. And then stemming from that, after this gap in care was really brought to the forefront of our attention, and thanks to participation from the city of Chicago, an RFP was actually introduced to develop a model for providing longitudinal care to Chicago area shelters. So it's currently in its infancy. It's just being developed, and it's actually just awarded to two of the partners of CHARGE. But what it will do is pair federally qualified health centers in the city with partnering shelters to provide longitudinal care and develop that long-term relationship to improve health management in the shelters. Continuing on, one of the largest hurdles we actually had to overcome, and this is something that's becoming even more important as we're entering the second wave of the COVID cases rising in our nation, is that we were really able to provide evidence of safe and effective engagement of students in clinical spaces during the COVID pandemic. So initially, when COVID arrived in the US, I think most administrations' first instinct was to pull students out of the clinical spaces due to obviously a lot of unknowns, concerns for wellness and health. But the fact is, what students really wanted and what our communities needed was an all hands on deck approach. And so through work like ours, we were actually able to prove that it was more benefit than risk to have students participate in the pandemic response. And then also kind of stemming from that point, our work, our documents, and our experience actually allowed us to bring these protocols and our procedures into other spaces of service. So as Zoe previously mentioned, folks on our team were able to utilize pieces of the PPE and hygiene protocols to continue running the South Loop Community Table, which also services folks experiencing homeless. And then myself and a couple other team members were able to take our student engagement procedures and work at Project Vita in Little Village, which was a site that really helped to provide robust testing services to the Latinx community in the Little Village neighborhood. And then the final outcome I want to end with, and what we feel really is the most important outcome, is demonstrating how effective we can be as health profession students when we collaborate to support and protect vulnerable communities. You know, not only are we numerous, but we are uniquely equipped with a set of knowledge and skills that make us valuable in ways that are crucial in this period of time when public health and numbers really are like the name of the game. And so what we hope we've demonstrated through this is that instead of health profession students being pulled away from the fire, so to speak, we actually hold a lot of value and potential, and we have a place in this fight and all fights for the betterment of the health and safety of our community. And then as we wrap up here, we want to really turn it back to you and say that this workshop, wasn't meant to be demonstrated or a demonstration of, hey, look what we can do, but more so a demonstration of, hey, look what you and your peers can do. As health profession students and folks in the public health and health professions, sphere, we are trained to understand the multifactorial way in which our environment and our intersecting identities impact our health and wellness. And I'm sure we've all identified communities and groups in need of an organized effort for support, before COVID, during COVID, and certainly beyond COVID. And often I think we look for programs and systems in place in order to do the work we're passionate about doing. But what we're challenging you to do is to look around and see where need truly is and be willing to take steps to address those needs in a new way. Don't be afraid to engage in the process of developing something that supports the folks you care about. And don't be afraid if the path doesn't look clear cut, because it probably isn't, and it certainly wasn't for us. And maybe you already have an idea of a group or someone in mind that you'd like to help, and there isn't anything within your institution or your community that's focused on those particular needs that you're really passionate about. So, how do you get started? The best place to get started, if you have mentors, peers, or other leaders that you admire, picking their brains is a great way to start that effort, because honestly, most efforts do share similar needs for people and resources. So to get ideas on how folks before you have kind of tackled those is a great way to start your efforts, because we don't need to completely reinvent the wheel every time. And just, a final plug, if you're specifically interested in the intersection of homelessness and healthcare as a student or a provider or someone invested in public health and the health of those experiencing homeless, there's a place at the table for you in charge, in other organizations like us, and we really welcome you there as well. And so we want to say a really big thank you for sticking with us through this workshop. And we have a couple minutes left for questions. We also have a couple slides left at the end just for acknowledgements. So if anyone has any questions, feel free to pose them now. And then Cary, maybe if you want to just flip through the acknowledgement slides, just to make sure that the people get acknowledged. There's a lot of help. Zoe, do you want to, oh, you did drop it already. Oh, perfect. Never mind. Yep. So Zoe just put this in the chat as well. We have a flyer that we've picked out, some of the most, salient points from our presentation. We also have a QR code on there with a link to a folder of resources. So resources from the city, links to websites and organizations that we like. Yeah, Stephanie just put her email in there as well for charge specifically. We all engage in other service opportunities outside of the work that we did during COVID as well. So we really love working with this community of folks. Do you have this info in Spanish? That's a good question, Monica. The presentation specifically.
I think that Monica, correct me if I'm wrong, but I think Monica may have meant the flyer, which I had already had plans in the works to get it translated. So I'm going to reach out to Maria and see if she can translate it.
Cool.
Thank you.
Our pleasure. Maria was actually one of our regular volunteers at PGM, and we kind of trade work back and forth, including translating. So should work out. Any lingering questions or thoughts or comments?
Well, I just want to echo again, thank you guys for coming. I think we are really enjoyed doing this work and presenting to you. So we're very grateful that you came and hopefully learned something interesting. I think you have our contact information, and some of us put it in the chat. More of us can also if you're interested. But I think that is the end of our presentation, but we will hang out in here for at least another minute if you guys want. But if you need to take a few seconds to regroup before your next conference presentation, thank you so much for coming. It has been really great to spend time with you today.
Great, thank you. What's next on the agenda is we have a lunch break scheduled for the conference from 12:20 to 1 p.m. So you can join your next breakout room session starting at 1. So enjoy your break for the next 40 minutes.
Great, thank you.